Good morning, colleagues. Thank you all for joining us today. We appreciate you taking the time, and we're excited about today's Link and Learn. Let's see if we could go to the next slide. So I'm Jackie Watson. I'm the digital health lead for Genesis Analytics, and I will be acting as the chair of this meeting today. So as we can see on this slide, we'll start off with the welcome, then turn to opening remarks from the Chief of Health Services from the Ministry of Health in Malawi. Then we'll turn to our colleagues in South Africa and Zambia for presentations on their CCMDD and DSD models. And then we'll have a facilitated Q&A discussion, which will be facilitated by ASRT, and then we'll close. So we aim to close off this session by 10:30 a.m. So just as a start, to welcome you all here today, the spirit of this discussion originated through the Gates-funded AI for Self-Care project, which is an initiative across multiple countries looking to ensure patients have access to the right information and commodities at the right time to support their health journey. Now, a critical component of that is allowing patients and individuals to collect medication outside of public facilities. The Ministry of Health in Malawi are still in their nascent phase of conceptualizing and implementing their own CCMDD program. And so we thought, why not turn to others who've already walked parts of that journey so that there can be cross-learning across different countries. So this is just to say welcome especially to our colleagues in Malawi who are here to learn from our presenters today. And I'm looking forward to a productive meeting and discussion. Now I'd like to turn over to Dr. Likaka who's the Chief of Health Services from the Ministry of Health. Over to you, Dr. Likaka.
Thank you very much, Jackie and colleagues. Thank you very much, Jack, colleagues. Let me recognize the presence of the Director for Quality Management and Digital Health in the Ministry of Health in Malawi. Minister of Health and Sanitation in Malawi, Dr. Gonans, who has also facilitated and is leading this work. I want to recognize all the colleagues from various agencies in Malawi, Malawi Postal Corporation, regulatory bodies, central medical stores, directors, deputy directors, in the Ministry of Health and Sanitation, and various agencies are represented. I want also to acknowledge the presence of colleagues from the Presidential Delivery Unit, the Presidential Unit responsible for strategy and manifesto implementation in the Office of the President and Cabinet. I want to also acknowledge the presence of colleagues, counterparts from Zambia and your team, Jack, colleagues from Gates Foundation, and everyone involved, our partners, local partners, SRT, colleagues. I think it's a great pleasure to have this interface meeting and learn more about the use of different models that are being used in Africa, South Africa to be specific, to ensure that services are as closer to the people as much as possible and they're accessible, also improving on the efficiencies. Colleagues in Malawi, this will be a big opportunity for us to see what is happening in other contexts and also learn 2 or 3 things. It's an open opportunity, I think, to learn more. I want to highlight that technology is a big thing that healthcare systems need to advance. The coming in of artificial intelligence should not be looked at as a threat in healthcare, but an opportunity to support healthcare systems gaps. And I think this coming in of the self-care is an opportunity that all of us are looking for. By the name itself, self-care, I think it should give us the leverage to know that it's the desire of everyone to be in control of their health and outcome. And in that aspect, as we are talking about universal health access, universal health coverage, artificial intelligence could be a tool that we need to leverage and take advantage so that we leave no one behind. We are looking forward to situations where health workers can't even afford to access, but using technology, services should be accessible. Models of care are changing. The health systems are facing lots of challenges, including shortage of human resources and the congestion in our facilities. It's a talk of the day. In Malawi, we've just witnessed how rapid issues of corruption in healthcare it has been a matter of concern even to the president. Some of these issues are coming in because people want to be seen quickly. There are so many challenges to access services. Now, any opportunity that can help to reduce congestion, I think need to be considered and advanced so that we reduce some of the bottlenecks in our healthcare. I want also to call all of us as we look at the user cases today to think beyond the concept and model that we are focusing on. To go beyond, I think, just where the patient is, but also to think about how we can utilize artificial intelligence in clinical decision making, how we can link our processes, care processes, the documentations, the guidelines that are helping us, the standard treatment guidelines, to advance the care of the patients in the context where human resource is bottleneck. We are looking forward to situations where using artificial intelligence, we will be able even to redirect patients directly to specialized care. We'll be able to use to advise patients in their appointments to services that are tailor-made to their needs. So we need to be thinking about various aspects that can help us in making sure that care delivery is enhanced and we gain more using artificial intelligence. So this is a very, very good opportunity. The teams would have been physically in South Africa to see what is happening there. I want to urge all of us to be open to the processes. Artificial intelligence is a new thing on the technology scope, but there are huge opportunities that we can utilize artificial intelligence. Also, let's look at the challenges in our context. What will be the bottlenecks to be even considered? Uh, I think we are all learning and we are all in this field to see, to solve the problems together. So any challenge that comes up should be an opportunity for all of us to put our hands together. I want to commend Genesis as well as Gates Foundation for the support. It's our assurance that Malawi is fully engaged to advance digital technology in service delivery. It's our key priority, and we look forward to working together with the team. So I want to welcome everyone and wish everyone a very successful meeting. Thank you very much, Jackie. Over to you.
Thank you so much, Dr. Lekaka. With those opening remarks, we've heard, needing to keep an ear open to hearing about some of the learning, some of the challenges and opportunities that South Africa and Zambia have taken from their implementation. So with that, I'm going to turn to Ms. Munsami from the NDOH to take us through the South African CCMDD program.
Good morning, everybody, and thank you for having me. It's such a pleasure to be here, and I think the speakers before me had echoed some of the challenges we face, not only as South Africa, but I think it's a global phenomenon. And South Africa, like every other country, has its challenges, especially in health. And if I have to turn back a decade ago, we had experienced a lot of challenges. We had, next slide, we had a lot of facilities that is overflooded. Infrastructure is bad. There were hardly any staff. Staff are aging. And a facility that was built for approximately 10 to 20,000 patients, now we're seeing in excess of 200,000. So obviously that infrastructure cannot withstand all the patients that is coming. And then in terms of maintenance, for South Africa, we have public works and they were supposed to maintain, but there's always challenges there as well. The aging health staff, the healthcare workers, although we do have a strategy, HRH, but we still do not seem to have the people there because of funding issues. Next slide. So again, these pictures is common. Like I was saying that if you look at this facility, the patients are all outside because inside is full. And with all of this in mind, patients at the facility, their waiting times are extremely long. And some of them merely go there to collect the medicine. Next slide. And this is what was happening. Over 70% of patients just went to the facility to collect the medicines. And as a result, they clogged up the system. So, and this is the traditional model. Whenever someone is sick, they go to a facility, whether it's the doctor, a primary health care, or hospital. And that model did not seem to be working. So let's get to the next slide. So most ideally, we should bring the medicine to the patient. But this is easier said than done. Because if you look at South Africa, next slide, we have this rolling hills, never-ending roads. Next slide. And then we have homes that are far away, that are not accessible, that is not even numbered. So how would we expect delivery to these patients? Next slide. So this is what we have. And South Africa is a mixture of rural, urban, peri-urban, and of course we have the metropolitan. So when we look at all of what South Africa is, take us to the next slide. Then we look at a model to bring the patient and the medicine to a convenient location. Next slide. So this model is what we called the CCMDD model. So before I go into the program itself, we have to look at what are the building blocks or the governance and why we have a strong foundation for the program. Now, the thing that I didn't put on here is the political will. You need political will to drive your healthcare because everything that you do requires funding. And funding ideally should come from the fiscus itself. There is only so much you can rely on donor funds. But if a program has to be ingrained, then it needs the treasury to fund that. And treasuries works on business case to see whether something works or something doesn't work. But they do not give you the seed money. In this instance, we are very thankful to Global Fund who gave us the seed money for the starting of this pilot project that started in 2014. And it was one of the NHI initiatives. So when we look at what we have, the first thing that we do have is the essential medicine list and the standard treatment guidelines for adults and children. Now, here we have a whole background of people that is working on this. The committees is ministerial appointed, firstly. Then you have the provinces joining in there as well. You have other people that the minister has appointed. They don't only work in government, they're also from private sector. So together with that, we have the baseline from what we can choose. To support that, we also have the medicine tenders that is from a national level, and then all 9 provinces procure from those tenders. There are instances where the provinces opt to choose their own medicines and they do buyouts, but that is not always the case. It is in some instances only. And then for this program, we have a national CCMDD task teams, and this task team is appointed by each of the head of departments in the provinces so that those people understand that they are representing their provinces at the national team. Then we have the provincial task teams, and this is constituted by the provinces, and then the office, my office, we also have inputs into the provincial task teams. We do try and attend as many as we can, but that's not always possible. But we do have the provincial task teams. Then we have the district task teams that looks at all of the facilities that is under that particular district and sub-district. Then on a weekly basis, we have catch-up sessions from the service providers. We have 2 currently contracted. And then we have all the provinces except for Western Cape joining on these catch-up sessions. And then we also have quarterly performance reviews for the service providers to ensure that they are doing what they're supposed to be doing, and we manage them through our SLA. So that is in a nutshell the foundation. And it is important to have a very strong foundation. Otherwise, what we were trying to do would not have been successful. Next slide. So like I said, typically a patient with a chronic disease is issued with a repeat prescription. And in South Africa, the prescription is valid for 6 months. And patients are normally stable. So they only come into the facility to collect, almost 70% of them. So these are the patients that are stable, that do not really need a clinical assessment at every visit. But they have to come because the medicines are at that facility. Staff are overburdened is an understatement, you know. And if, example, a facility has 5 members and 5 professional people, you can be assured that one is off sick, one is on maternity leave, one had to go and attend some course or another, then there's a tea break and lunch break. So how can patients be seen when you have staff that's supposed to be there that are not there due to other commitments? That is necessary as well. So from the patient's experience, these long waiting times aids to the frustration what they feel at a facility. And if there's only one person or 2 persons to see them, to consult with them, and then obviously they do not get the hearing that they're supposed to because time is always short. And most often, the facility do run out of medicines. And so this results in this vicious circle of non-adherence, poor health outcomes, and the strain on the patients in terms of transport cost and loss of income if they do have some sort of contract work. Next slide. So CCMDD is the flagship program from the National Health Insurance that provides an alternative access to chronic medicines for stable patients. Now, when we read the green paper, you would see that it's very clearly articulated on the external pickup points where the green paper alludes to patients collecting from schools and creche and places of worship. And that's why the external pickup points would provide patients with a more convenient option to collect their medicine parcels. So when we moved to the white paper, then it was all about the reforms, whether it is health system reforms or whether it is pharmaceutical reforms, that was then in the white paper. When we went to the bill, it became more refined. And now when it is an act, again, more refinement when we talk about the benefits, right? So in this instance, the pickup points that we contract is in the community or closer to a workplace. And this as well is convenience for the patient so that they can also have a choice of where they can go collect. As remember in the previous model, patients never had a choice of where they could go. They just had to go to the facility. And also, if you look at the demarcation, they had to go where they live, they had to go to that facility. So now patient had choices and they could choose as to where they would want to collect their medicine parcels. And of course, there is no out-of-pocket payment. So this again tells us that we need the political will. Next slide. So in developing the objectives, what we did is we looked at all the problems and then derived the objectives. And it is in no particular order, but we had to have an improved access to chronic medicine, improved quality of care, improved patient experience, improved treatment adherence, improved supply chain processes, and I'll come back to supply chain. Then improved available data for decision making at all levels. And then we needed to decrease the stigma. The stigma is something that we've been trying for years. Then we need to reduce the workload for public health facilities and reduce patient waiting times with better time management. And then we needed to decongest the health facilities through the use of the alternative pickup points that we have contracted from a national level. So obviously these objectives very difficult initially, but we went through them and we ensured that we had results. Next slide. So if we have to look at before CCMDD, the patients had to go to the facility whenever they had an issue, or if they were acute, they went there. If they had chronic, they also went there, which makes it about 6 visits per year. With the CCMDD visit, they only had to visit the facility 2 times and the pickup points 4 times. The average waiting time at the facility was 4 to 5 hours, and at a CCMDD visit was about 10 to 15 minutes. But in 2022, this is now the third tender, we opted for a 3-month supply. So the patient went to the facility once, and then they went to the pickup point once, and the average waiting time was 1 to 10 minutes. So this again showed us over time, patients supported the program because it was at their convenience. They could choose where they wanted to go. And also adherence, we had research being done to see whether adherence was there. And yes, this research did prove that the adherence was definitely there. Next slide. So this is the patient's journey. In this program, we only look at the stable chronic patients. They need to meet the criteria, meaning that they need to have a South African ID, a passport, or asylum seeker number, and they must be stable. When we say the patient agrees, meaning patient needs to give consent to be on the program, the patient then choose where they want to collect the medicine parcel, and then a 6 months prescription is issued, and the first dispense is always at the facility, and then the patient collects the subsequent dispenses from their chosen pickup point, and then after 6 months, the patient returns to the facility. That is the basic patient flow for the program. Let's go to the next slide. So we have more than 100 conditions, and here we can see that a lot of the conditions are common worldwide. We also have children and adolescents. Next slide. So this is the high-level process. The patient goes to the facility, they get a prescription, then our courier come collect the prescription, they take it to the central point, they dispense it, and then they take it back to where the patient collected. In green is all public sector, and the red is private sector. In terms of a pickup point that has to be contracted, they have to be pre-qualified. Then we do an assessment. then they have to sign a service level agreement before they can become an approved pickup point. The adherence club and facility fast lines are at facility level, and we do not contract them because they are public. Next slide. If you could just enter. So here we'd see how the very same model, enter again, where you could include private sector. All they have to do is to ensure that they have our system, which is called the sync system, and then that will feed into the prescription that then goes to the courier. If you can enter again, please, until the slide is, yes, again, one more time. And then you could see that we can safely bring the private sector into the public sector as well. Next slide. Because one must know that when a patient has a medical aid, they do go to private sector. When that medical aid runs out or the patient can no longer afford it, where do they come to? Back to public sector. So we have to ensure that the treatment guidelines is applied throughout private and public sector. Next slide. So this is over the years how we've grown, and the slide tells us that year on year on year, we just keep on growing. Next slide. I'm going a little bit faster because I've said I've just got a few more minutes. And these are just on the program of what we are seeing currently. So if we look at the lines where it shows us the number of active patients and then the number of PMPs that is delivered, you can see that the number has dropped in terms of PMPs because we moved away from 1 month dispense and 2 month dispense to mainly 3 month dispense. Hence, that is the drop, but the numbers still grow. Then if you look at the number of facilities that is taking part in CCMDD, it is almost all of the PHCs and some hospitals. And so we more or less doubled the number of facilities where patient can go collect. And then if you look at the patients per facility on average, it comes to a fairly good number. Next slide, please. This one talks to the pickup points where we have 3,022 pickup points that we've contracted. And we see that almost 60% of patients do collect at external pickup points. That also says that patients are comfortable to go to their pickup points and collect. Next slide. In this slide, I wanted to show you what we capture in terms of the disease process. So we have about 58% of patients on ART only, 24% on just NCDs, and 18% on both the comorbidities. Now, this gap, the red line in between there, has been increasing over the years. And here we need more information to say that people are getting older and they are developing other comorbidities. It's not only HIV, it is also the comorbidities that patients have. So when we look at patients, we need to treat them holistically. Therefore, CCMDD is a patient-centric program. And then you can see from most of the other provinces, if you look at Northern Cape, they are sort of maintaining 42% of just ART and then 42% of the ARVs and then 16% just on the comorbidities. Most of the other provinces need to come back to ensure that they do capture more of the chronic patients. Next slide. So this is some of the indicators that we capture on our M&E. Our M&E is done every single month, and then we do once a quarter. We do the results from that quarter, and then it is pre-populated with those indicators, and it is weighed so we know exactly that nobody can interfere with the questions and how we structure the questions. But what I also wanted to show you here was that patients' average waiting time, everything is less than 10 minutes. Next slide. Now here is our different modalities of the external pickup points. On the first one, you will see it's a sharp left. This is a refurbished container. And in some bigger containers, we have a private nurse practitioner that is wholly private, but then they also hand out parcels for public sector patients. And it's a win-win because we have private sector and public sector working together. The next one shows you a van. Now, this is where the hard-to-reach places, we normally park at a school or a library or open parking, and then the patients come and collect the medicine from there. We also have the home delivery, the bicycle, so that patients that are critically ill do not have to come to the facility. There is criteria for them. And below, we can see that there is the smart lockers. I don't think I included a video on that, but we can do that. And then we look at Medirite. Medirite is also a grocer, a greengrocer, as well as everything under one roof. And then why not the medicines there as well? So Medirite is also very popular in patients choosing. So they just have to transport themselves once to where they want to purchase all their grocers, and then they also pick up the medicines at the same time. And the same will happen to our clicks, which is the corporate, SPA or Discem, and then also the post office. Next slide, please. So this is a prescription that I cannot read, and I'm sure you cannot read as well. Next slide. But this is what we received. And then also we can pick up errors, so you can see what was prescribed was hydrochlorothiazide, and what was dispensed is definitely not hydrochlorothiazide. Next slide. So if a doctor prescribes epilepsy, and then the pharmacist issues the epilepsy, I mean, really? So these are the things that we picked up from a manual prescription. That is why, next slide, we have to go digital. So when we looked at the system, when we started off, we have the paper-based prescriptions. And then these copies were made and were sent to the service providers. That was initially. Then we started with a prescription book, meaning that the clinician could choose the disease and the protocols and what they wanted to prescribe, also indicated there the supply, and that went to the service provider. Then we started with our system with the electronic prescribing. We had lots of challenges in getting to where we are getting. We have 8 provinces, 42 districts. 42 districts believed that their prescription was the best and we needed to choose theirs. So there was a lot of haggling. But when it came down to the system, we developed one system for everything. Then we also developed the parcel management, meaning the service provider will deliver the parcels to the pickup point, and then the pickup point scans the parcel into the system and then scan the parcel out to the patient. Then we know from a national level that patients have collected. If the patient did not collect within 7 days, that parcel is then uplifted electronically. The service provider would get a message to say, please come uplift this. And then we have a reporting module. You can see exactly how many patients are collecting. Anything that you want to see, there is a report for that. But we still have 14 districts still to roll out the sync system. Next slide, please. So this is just showing you that how South Africa had made a contribution into putting patients first. And this was one of the very first research that was done. And then we presented to the conference, and then that was taken into, but there's still, oh no. Can you still hear me? Okay, next slide. So we still have a lot of research that has been conducted. And then we also have a lot of awards for the program. Firstly, it was by CPSI that gave the award to CCMDD, and I think we basically got all the categories. And then the next was from South Africa to Africa, where we won the APAM Awards. And so it goes on, and then also in Portugal, we won first place there as well. So there's a lot of those things as well. But we can safely say that CCMDD is a proven successful patient-centric approach to service patients in a manner that is beneficial to patients, departments of health, communities, and creating lasting partnership with private sector. Next slide. We're almost there, Jackie. Next slide. My favorite slide, collaboration. Next slide. Thank you. I think we missed one slide where it says developments, but it's okay. Thank you so much for lending me your ears and listening to me. I know this is my passion and I can speak for a lot, but when you gave me only 20 minutes, I just wanted to cry. But thank you so much. You've been a fantastic audience.
Thank you so much for that. And it does seem like it's a much broader conversation. I just want to highlight to colleagues that we will have time for a Q&A shortly. But without further ado, I'll hand over to Dr. Ziambo from Zambia to take us through their differentiated service delivery models. I'm just checking. Dr. Ziambo, are you there? If so, and if you're talking, you're on mute.
Hi, good morning.
Morning.
It's morning for everyone on the call. My name is Jose Ziambo from Zambia. I'm coordinating the DST work in Zambia for the HIV program. And I'm glad to be here to share Zambia's journey on the DST models. We can move on. And so Zambia's journey on the DST models started quite some time back. And I thought before we could do that, I could just give a picture of the Zambian context. And so we are, according to the 2021 statistics, we're 21 million. And more females than males. And then we have about 2,900 facilities. Next slide. And our prevalence stands at 8.7. This is a more recent population survey data from the demographic health survey that was done in 2024. And so we do have provinces that are urban in deep green with very high prevalence. And there's some of the rural provinces in light green that have a low prevalence, as you can see on the northeast and then on the northwest side. Next slide. This here shows us according to the age prevalence across the years from 2000 to date. We can see a step down, and then also the percentage of women and men aged 15 who are HIV positive has also been, we can see, has been increasing. Those that have been finding. Next slide. I'm a pediatrician by profession, by practice, so I thought I should also highlight this important slide as well. So we have about 1.2% prevalence for the pediatrics, and they are more in the urban than in the rural. And then the bigger figure prevalence is noted in 0 to 10, which has an implication on how we are managing our PMTCT as well, because that's what's adding to this number. It's mostly vertical transmission. Next slide. So here we're looking at the prevalence by residential area. We see that it's higher in the urban than in the rural, then also higher among women than the men. Next slide. So that's the new infections that we've estimated using our spectrum file. And so from 2025, where we're working with 29,000, but somehow it has increased to about 32,000 in 2026. We hope it goes down by the time we get to 2030. Next slide. I estimated prevalence by age group. We can see that this is by age group from 2025 across to 2030. Seems to be increasing for the adult, but reducing for the pediatric population. Next slide. So this is a picture that I thought I should share with all of us, so it gives context to the DSD models that we established. So we have had a cohort that has been increasing. I didn't add the 2017, 2018. Our cohort was around 800 during that time, and then we had a lot of acceleration in the program that led to this huge increase over the years. And so that in itself required that we decongest our facilities so that they respond accordingly to the increasing number of individuals that we're going to be putting on treatment. So right now, as at end of 2024, we had 1.3 million individuals living with HIV. Next slide. This is the cascade according to against the spectrum estimates in 2024. The children who know their status and on treatment, about 70%, and then the adults were about the adolescents, 98, and then the adults about 99. Next slide. I thought I could also show this. I know it's a lot of red. This is the overall HIV mother-to-child transmission rate, and overall we are below the less than 5%. I want to draw attention to the fifth column, where the percentage of HIV-exposed infants of unknown outcome. That's where we are very concerned. Those that break through the period of HIV exposure, who are known with their status at end of 24 months, remains high and a pretty big concern for us. In our triple elimination agenda, we want to ensure that hepatitis B is being tested and syphilis being tested. So we're doing fairly well on the syphilis, but not so good when it comes to hepatitis B. Next slide. So our goals for the HIV program really is to achieve 98% leakage to care. 98% retention in care, over 95% in viral load coverage and suppression, and then screening for AHD and screening for hypertension comorbidities. We also would like to see over 95% on DSDs, including MMDs, multi-month dispensation. Next slide. And so for the program to achieve these, we believe that DSDs, including multi-month dispensation, need to be implemented across all public health facilities and in all communities as much as we can possibly. Next slide. And so the journey of our DSD, we had to do some evaluation to understand the facilities across Zambia. And so this table here shows you the type of facilities that we have and the TX the treatment current that we have. On top there, we have got facilities which have got over 5,000 treatment current, and these facilities are 29 facilities across the country, and they make up 19% of the total TX and so that TX is about 241,000 individuals on treatment. So you would imagine this amount of individuals split in 29 facilities, what sort of congestion that would have at our facilities. Then we do have other facilities of interest, like the ones which are 1,000 to less than 3,000 individuals. We have a lot of those, over 200, and they make up quite a huge percentage as well, about 31%. And these also will require a form of DSD to decongest those particular facilities. And so having an understanding of how our facilities are shaped then helps us to understand what sort of models we can put in place in our facilities that are going to support treatment adherence, treatment retention, and all of that. Next slide. And so the build up to our scaling models really started somewhere around early 2014 as pilot studies that were being conducted by various implementing partners. They were in different places, different sites, different provinces conducting these pilot studies. But then as we were approaching 2016, 2017, there was a need to actually scale these models. And so stakeholders engagement meetings were held and results dissemination. Then the ministry, the HIV program approved some of the models, and some of the models were quite cost involving. And so one of the biggest push that the ministry drove for was a 6-month multi-month dispensation, and also the fast track models, because these didn't require any additional resources or support, and they didn't have a heavy reliance on IP support. Then somewhere around 2017, we joined the DSD community of practice, the Southern and Sub-Saharan, which is led by the CQUIN, and then established the DSD task force, which was created to coordinate and oversee and monitor the implementation of DSD models, developing new ideas and seeing how that can work out. And so TORs were developed and an implementation framework was done. And then this led to the revision of the Zambian Consolidated Guidelines. It went into forecasting and quantification in response to the particularly multi-month dispensation. Next slide. So in the next slide, you see how the journey went during this period. So 2013, a lot of partner-driven work. 2017, DSD became part of the National HIV program. And so we had different models, which I'll explain later. And then we had implementation across the country. 6MMD started in 2019, and we did release a memo as a ministry included in the consolidated guidelines, and then we had the DSD framework developed. 2020 came with COVID, and that in itself really pushed the 6-month dispensation that we had hoped to achieve, and so we scaled in all the facilities for this model. Next slide. So the adopted models included the 6MMD fast track, the community adherence groups, community delivery points. This we did a lot during the COVID, and community pharmacy pickup points and the community health posts. Each one of these had a rationale that we had to think through. So the first two, we just thought that these ones just were low-hanging fruit that required only commodity security, and so we ensured that it was easily achievable and scalable at the time. Community adherence groups, these involved the recipients of care themselves, and quite a lot of ownership was instilled in the recipients of care, and it was an opportunity for these groups to have other mutually beneficial non-medical benefits, like they would have village banking groups just beyond the ART. So this is what was helpful. It was difficult to put to scale because it required a lot of resource, extra HR, and a lot of work need to be put. And then we had community delivery points also requiring extra resources. Pharmacy pickup points also required extra finances as well. And then community hospitals was the rationale. These ones was to be placed in business places, markets where recipients of care are operating. So it helped them minimize costs for transport and disrupting their businesses. Next slide. And so this is as at by September when we ran this last year. This is where we have in terms of the multi-month dispensation, and the gray is the 6-month. Mostly the ones that are less than 3 months are children, but then we have got those that we still have to monitor in the 3 months, and then the 6 months are the most people on the multi-month dispensation. Next slide. Next, and so there's some supply chain considerations that we had to put in place. Next slide. That helped us with the planning for this scale up. Forecasting, we had to change the bottles from 90 to 180 bottles, and focused in that direction. Even the pipeline procurement and procurement lead time, we had to work together with the MOH, ZAMSA, and other supply chain partners with monthly meetings where we had to adjust accordingly in terms of procurements and track the commodities available. Next slide. We further looked at the inventory management. This was also important, particularly at a regional level, ensuring that this is speaking to the national level as well. Storage capacity as well. We had to be reconsidered at facility level, and we have to do a lot of orientation of staff on the ground to ensure that they can accommodate the supply that is being delivered in those sites. Next slide. And then distribution and logistics, these had to be planned very well in terms of routes and time when these had to be delivered. Quality assurance, in bulk movement of things, quality sometimes is compromised. So we thought we needed to ensure adherence to quality during this period. Not forgetting the information systems, they had to be upgraded. We had to add the 6MMD dispensation in the smart care because it would refuse. So we had to add that and use real-time data to anticipate stock needs and prevent shortages. Next slide. So in the next slide, I want to show some of the lessons that we learned. We did acknowledge that wastage of drugs can happen with short expiry dates, and so we had to we learned that quickly that we needed to manage that, and also the risk of recipient of care taking expired drugs was higher, and so we also had to do a lot of counseling to the recipients of care, and then also we reduced facility visits to twice a year. It improved adherence, saving costs and time for the recipients of care. 6MD data elements were incorporated in data collection tools. Then we shifted storage from the facility to recipient of care as well, because they would be the one holding the drugs. And also the recipients of care visiting sites twice a year. Healthcare providers had more time attending to recipients of care who actually needed the care at that particular time. Next slide. So looking ahead, and I think we're doing this through a sustainability lens. We will be piloting a 12-month model. We know this will have a shock on our supply chain, and so there's a pilot trying to understand what implication this would have on our supply chain, and so ensuring that there's feasibility supply chain component. We do know about the clinical outcomes. We've analyzed some data for those that would get more drugs and the clinical outcomes in terms of viral load suppression, adherence, attrition. I think that's evaluation is still being done, not yet ready for dissemination. We would like to enhance fast track models by reorganizing the facilities and also revamp community-based DSD models. These are very difficult, but I would like to see how we can do that. So we're hoping to utilize community health posts supported by local authorities or community organizations where they agree where they don't pay rentals, and then the ministry is able to facilitate by placing providers there that can help to dispense and monitor recipients of care. So also integration of DSD with other program areas is something that we're looking at, and promotion of full model mix at facilities, including population targeted DSDs. So this is how we're seeing how we're going to use DSD models as part of the sustainability in this with a current funding landscape in the program. Next slide. So really, decongesting facilities through DSDs enhances quality of HIV services across the facilities. And the 6MD models are easy to push to scale with minimum extra resources requirements, as long as the supply chain pipeline is managed and monitored closely. And then adherence to treatment improves the viral suppression rates and really improve, which is something that we have seen in our case. Our viral suppression levels are above 95 in those that are get to be tested. We just need to improve on our viral load coverage, which remains quite a difficult thing. Yeah, thank you so much. Next slide. So this is some of our partners that have been involved in the response, and we do appreciate them. And so I will welcome questions now beyond this. Thank you very much. I hope I managed to do this within the time limit. Thank you.
Thank you so much, Dr. Ziambo. I'm going to turn now to Dr. Chitila to facilitate our question and answer session. So over to you.
Good morning, everybody. Thank you very much, Jackie. Before I begin, I just want to recognize the Chief of Health Services in Malawi and all the directors from our ministry, but also I recognize representation from the Presidential Unit on Strategy, and I recognize also all the various CEOs and executive directors from our regulatory bodies, and also, of course, recognition of the presence of gates and all the other key stakeholders and my colleagues from the implementing partners. My name is Mateo Dashitela. I'm a member of the one of the members from the implementing partners here at ASRT. Well, I must say that I'm so delighted to go through these two presentations from our colleagues from South Africa, Munsame, and then our colleague from Zambia, Mr. Ziambo. Thank you very much for this. It's very delightful to go through, understand the experiences that you've had, because here in Malawi, as you are aware, of course, through our ministry, we are into a debate in terms of how do we proceed from here on. So how else to do this other than to learn from others? As I say that we don't reinvent the wheel, but rather learn lessons from elsewhere. And this south to south learning is very useful for us. So we are thankful, extremely thankful for creating the time, but also taking us through this journey that you've gone through and the lessons that we can pick from there and how we can make use of that. Now, it comes across to me clearly that you are enjoying the benefit of the systems that you have implemented, the CCMDD system in South Africa, the DSD system that you have in Zambia. You are reaping the benefit of implementing those systems. And I can see that you have one that this experience, the patient experience, having improved positively, that the patient is having a choice, but also their timelines in terms of how long they spend looking for refills of their various medication that has improved, but also how the system itself, the health service delivery system, is benefiting from that. Because we are aware that in most countries, populations are growing. We are not really reducing our population levels. So both the infrastructure and the human capital has to respond to this. And this is a very good example of how we can respond to some of the elements. And the choice that we provide to the patient, very critical, so that we can cut down on some of these non-compliance, but also just having the lack of services in general. So my words are not enough. That really we are extremely grateful to both of our presenters this morning, and thank you for the lessons that you have shared. So my job this morning is simple. It's just to open the floor now for questions. And feel free, you can post some of the questions in our chat box, but also if my colleagues at Genesis can also help me to record some of those questions so that we can always reflect back on them. Should you raise your hand, I'm not aware of it. If you could help me at Genesis to pick up some of those hands which are being raised. I see that there are already a number of questions in the chat box. For example, there was a question on what happens when the patient doesn't pick up within a specified timeline. How does your system, both systems, of course, in South Africa and Zambia, how do you respond to that? Of course, I also had another element to add to that. The cold chain commodities, how do you manage that, or are they part of the commodity list that you use? So let me open up the floor for questions. Thank you. But I can allow you to start with those two questions. How do you manage the delays in the pickup if the patient doesn't pick up? South Africa, how do you deal with that? And then within your list of commodities, the cold chain commodities, how do you deal with those? Thank you.
Thank you so much, Doc. So on the first one, where the patient does not pick up on time, So what we've done over the years, when we started, patients had 14 days in which to collect. Then we reduced it to 7 days. And the reason for that was all our packaging was 28 days. So if we extended it any more, then patients would not
Sorry.
have the pills. So that is why we have the patients to collect within the 7 days. If they do not collect it within those 7 days, but firstly, when the parcel leaves the service provider, an SMS is sent to the patient to say that you need to collect your parcels. It is at the pickup point, wherever that may be. If the patient doesn't collect within 48 hours, a reminder SMS is sent from the service provider to say, please go collect. In total, the patient has 7 days in which to collect. If the patient does not collect within that 7 days, then that parcel is uplifted. Then the patient needs to go back to the facility and wait in a line. Now, most patients do not want to wait in a line. So our MME also showed us results where patients collect at least 2 days before their due date. A lot of them collect on the due date, and few of them do collect within that 7 days. That's the first one. In terms of the cold chain, in our first tender, we did have the only cold chain item, which was the insulin. And in terms of that, the reverse logistics was extremely expensive. And then a lot of these products, as we couldn't use it again. So if we looked at the cost and the wastage of that, it was not suitable to put it on the program at that point. But we have had learnings. So also, it was at a time when South Africa was having a lot of power outages, and normal fridges would not suffice. So that is why we then said we will remove it for the time being, but it's still on our tender for us to do. But now patients do go to the facility to collect. But much later, we will include it when the settings it becomes more comfortable for us, and then patients adhere a lot more. Then we will put the cold chain back onto the program. Thank you.
Well, thank you very much. Really very insightful. Any comments from Mr. Zambo?
So for our we do not really have the CCMD MDD models in Zambia, but mostly the ones that we really put to scale is the 6 months MMD. So for that one, it's facility collections, and it just reduces their visits to twice in a year. And yeah, so we don't really have any challenges, and then we don't use all our commodities that we give our recipients of care do not require any coaching systems. Thank you. Because we have eliminated the syrups for our children, so we don't have syrups in our regimen anymore, and so there is no need for the coaching. Thank you.
Thank you very much. Yeah, so colleagues, like I said, let's open the floor. Let's make use of this time. We have our two colleagues from South Africa and Zambia. Please feel free.
Dr. Chitila, we've got a question here around working with private pharmacies. There's a question on How do the logistics costs compare to the model where patients come to collect directly from facilities, as well as whether Zambia is collaborating with private pharmacies themselves?
Quite right, yeah. So which means there's a component of tracking and managing the data, comparison of the cost elements, whether the engagement and the service delivery with the private sector, or we are allowing the patient to collect directly. Yes, you're quite right. Dr. Zorowere, I can see you online. Please go ahead.
Thank you so much for the opportunity. I have really loved the presentation. They are pretty insightful. One of the questions that I had, Dr. Gonani has raised it in the questions. However, I wanted to understand issues to do with security. What has been your experience so far to track the products from when they are prescribed all the way to the patient being able to get it? Have you had circumstances where you have lost some of those products, or who is answerable? And if not, how do you maintain a tight security to ensure that there is no pilferage through the process? Thank you.
Very so much so. Okay, Munisame, Mr. Zambo, could you attend to those two?
Yes, thank you so much. So regarding private pharmacies, so this wasn't something that was generalized across the country. It was in specific regions and more in urban districts. And so, this was coordinated mostly by implementing partners because they would be need to recruit recipients of care who would want to collect from a particular pharmacy point. And so the engagement then would be that the pharmacists would actually store those some of those drugs, and so they would have a record and they would be attached and linked to a facility, and so they would have a record of drugs that they are keeping for a record of recipients of care who pick up from that spot, and so they would have that link, and so most of the IPs would help facilitate that, and there would be a stipend that through the implementing partners that they would agree with the pharmacy that for them to offer that particular service. And so that's how that was coordinated. And so because of that linkages, even the pilferage was monitored closely because they would have to account for every drug that would be dispensed through those community pharmacies. Thank you so much.
Okay, thank you. Munisame, any comment on that?
Oh, sorry, maybe I could also respond to the question in the chat about regulatory policy. So I think under the framework we were operating as DSD, most of these private pharmacies have, particularly in the HIV program, there's been a lot of task shifting, which has been allowed and permitted, I think, from inception. So regulations had actually been eased in terms of dispensing the drugs. And so as long as the pharmacy has got technologies to a pharmacist, they would be able to dispense that. Then what is considered as in the community, like the non-medical personnel, these would only deliver. They wouldn't be the ones to prescribe. The doctors, the nurse practitioners would prescribe. Then these non-medical people would only deliver to the recipients of care. They wouldn't prescribe the drugs. Thank you. Thank you so much.
Thank you very much. Munisame, any comment from you?
Yes, thank you. So when we look at the pickup point, a pickup point is merely where the patient collects. A prescription is not dispensed there. It's just the parcel that is there. And patients collect a parcel. And most often, the people that issue the parcel to the patient, they are not professional people, but they are trained people. They are trained how to identify the patient, identify the parcel, and hand over the correct parcel to the correct patient. And that is where the scanning in and out of the parcel become necessary. So you don't need medical people for that. Then when we look at our facilities, and we've indicated that we do not have so much of medical people, meaning the nurses that can prescribe. They are called authorized prescribers, or doctors that prescribe at hospitals. So what we have done is that the clinicians can write the prescription, and then it goes to our service provider. We have contracted 2 service providers, and they service the 8 provinces. So within the service provider, that is where everything is dispensed. We have the responsible pharmacist, we have overseers, we have order processors, we have the pickers. All of them are pharmacists and pharmacy assistants. So everything that a facility should have done is now taken over to our private sector. Now, our private sector as well, they have influenced positively the processes that we cannot do in government. We have a system, and we don't pay anything for it from the service provider side in terms of the various compliance. And we also have not a lot of service providers, but the service providers that we do have, some of them have been with us since inception. So they grew with us and they came along the journey. And everything was not about the profit. It was also about how we can get the medicines to the patients. So in one of the slides, I think in most of the slides, you will see the term double up meds. Now that's a colloquial term in South Africa, meaning shortcut. And patients understand shortcut. So if you are stable, then you can take a shortcut to get your medicines, right? So CCMDD is a very long word, and a lot of people do not get it right. Hence, when we branded the program, we branded it as double up meds, shortcut to your chronic medicines. So like we say that in public sector, we do not have luxury of so many clinical people, right? So besides the clinicians that are seeing the patients on a daily basis, whether they're acute or mother and child or whatever, there is restricted resources there, especially in terms of human resources. Now, if we look at the cost, what is the cost of dispensing the medication to the patient at a facility, and what is the cost of dispensing that medicine at the service provider? At the service provider, it is much, much, much cheaper, right? So we also have what we've completely overhauled the supply chain process, right? So if you look at the facility, a province will place an order through the supplier. The supplier then gives it to the wholesaler. The wholesaler then delivers to the hospital. Hospital then delivers to the clinics. So that very, very long supply chain process, we've cut it down. So in CCMDD, we just have from the province that places the order with the supplier delivers directly to the service provider. So immediately we have cost savings in terms of transportation. Immediately. That's one of it. Because we are doing bulk dispensing, and because the service provider have all these professional people and they can afford to pay for it, what we pay is per parcel. And included in that is they must collect the prescription if there's manual prescriptions, or through the API get the prescriptions. They need to ensure that the prescription is correct and meet the guidelines in terms of our EML and SDGs. Then they need to ensure that they have the stock on hand. They dispense it with the different labels. That is why I wanted you all to see the box, but I think we missed that slide. And then if patients don't collect, that reverse logistics is included in the price for the dispensing and distribution. So whereas the cost of issuing or dispensing the medicines from the clinician rooms by a professional person that is in excess of 90 rands per person, a service provider does that for 26 rands. And that means they also deliver to our facilities, the parcel that is, and then also to our contracted pickup points. So then we also, when we say we completely overhaul the supply chain, so also we have Global Fund that is looking at the supply chain processes within the depots of the different countries. And what they found that in South Africa, the service provider, what we do there has changed this model. It became easier and simpler. So if we have the 9 provinces are phoning a supplier to say, please, I need my ARVs. I do not have TLD. I do not have the DTG, whatever dosage that is. Now you just have 2 service providers that will phone that service provider. So on that end as well, we sort of decrease that bureaucratic tape. So when we look at the medicines that's coming in, we can track it per batch. If there's something wrong with a batch, we can immediately have a recall because the service provider system, the inventory system, and the warehousing, together with the dispensary, you can do all of that. And we made that the service provider responsibility. That is why we do compulsory stock take twice a year. And at any point in time, we can visit the service providers to ensure that they are receiving the medicines correctly, they are storing it correctly, they're dispensing it correctly. All of that is open processes, and we can always go there, and I do go there a lot of times to ensure that everything is running smoothly. I also wanted to show a video of the service provider, but maybe we can do that the next time. So you can walk through, because remember, the number of patients that we are seeing is excess of 3.8 million, and it is increasing. So we need to ensure that patient, that one patient in that rural area, make sure they get their medicines. Whatever that modality is that they have chosen, they must get it at that correct date and time. And so that is what our aim is to do. And then I've also indicated we've done research, right? We've done a lot of research. One of the very first researches that we've done, you can Google this one, is the medicine errors. Medicine errors have decreased radically once we appointed our service providers to run the CCMDD program with us. And that again is private sector, because they have systems that in government we don't have as yet. We can get there, but we're not there yet. So that is why we also need private sector. And then I also alluded to the treasuries. And treasuries give us money. And every year they have been giving us increasing in terms of the fund. But every year we exceed our target, every year, because the patients all want to be on the program because they realized how easy and convenient it is for them. They can also send a proxy to collect, but it is registered on the system that a proxy will come and collect. So these are a lot of things that over the years we've tried, we've tested, some we've ruled out, some we put into implementation and things. So let me stop there for now. I know I can talk a lot.
Thank you very much, Munsami. That's very, very informative indeed. There's a lot of information there we can pick up. Yeah, I've got two additional questions coming through to me here. One is on awareness. As you know, that there's no point in having a system if the users are not aware the system is available or the service is available. How did you manage to achieve good awareness for those potential users of the system? How did you sensitize the users of the system? That's one component of the question. The other one is regarding guardians. Some of the chronic illnesses require that there is a guardian who is managing the process. How do you navigate that, making sure that the client or the patient is being serviced, but through a third party? So maybe I can start with you, Mr. Ziambo, although there's also another additional question specifically for you, Mr. Ziambo, is the idea that what is the proportion of the DSD financing that is supported from the domestic budget compared to the support you have from the donors or any other external funding organizations. Over to you, Mr. Ziambo.
Sorry, before we get responses, I'm just noting we are over time and we would have to close the session pretty quickly. So if I could ask just for as short as possible responses, and we can also see if we can get extended responses to share after this session. But we only have a minute left. So yeah, thank you.
Thank you. Mr. Ziambo, if I can get your response, and then we'll quickly move to Munsami to give us a...
Sure, thank you. Like I kept emphasizing, the 6MMD, the fast track, requires no resources at all except having a very secure supply chain. So that it has got no donor support in any form. The ones that have got donor support are the community health posts, the pharmacy pickup points. Those are the ones that tend to have extra resources coming from funders. And the community, that right now the government is employing what we're calling as polyvalent community-based workers. So these are now will be supported by the government. So most of this work will actually be government and domestic supported rather than donor supported. So we see that DSD models will continue. Thank you so much.
Thank you. Quickly, Munsami, what's your response to that?
Thank you. In terms of the different systems and how we went about doing it, we had a lot of roadshows, campaigns addressing communities directly, pamphlet, posters, radios, all in their own languages, and we explained the program to them. That is why a lot of the patients can resonate with Double-Up Meds. And then also what we found in South Africa is word of mouth. Patients, when they receive a good treatment somewhere, they tell their friends and families and neighbors and whoever. So that is a very, very good way of communication. Then we have trainings for the pickup points on how they handle patients. If there's a query, what happens? We also have learnings like through WhatsApp. We have learnings through our different training that we hold. And then in terms of human resources, I'm the only permanent person that is appointed from the National Department of Health, the only person. I've got 4 others that is donor funded, and we're busy in the process of getting them into the department. So we worked with a very, very skeleton staff, but what we did is we harnessed private sector as well as all of, when I said the building blocks, we harnessed all of them as well to come into the program. So once that was done, and then also we did not limit it to just ARVs, because that's where the issue of stigma comes into South Africa. So when you opened it to the NCDs, the issue of stigma was basically gone. And then everybody received the same packaging. There's no difference between the ARV and the NCD. So patients feel very comfortable to go and collect the parcel in front of anybody because nobody knows what is inside of that. So that for us was the key learnings. And then every year, what we also do during our M&E and workshops and things is that when we're out in the community with the patients, they tell us what they like and what they don't like. That is why from now, initially we started with one label, but now we have 2 labels. The other labels tell them your next collection date is this. It tells you it's the last repeat, go back to your facility. And there's a repetition in that because also on the appointment cards, where we also have the service provider, toll-free number, WhatsApp number, please call me numbers and all of that. It is still on the patient's parcel as well.
Yeah.
In terms of costing, we did do evaluations, 3 evaluations and stuff. So that as well tells us that the program is definitely a cost saver, because when you want to implement the national health insurance or any other programs and things, we can look at what is the cost to run this program as opposed to getting the patients into there without increasing the supply of the medicines. And we do know that even when we see it in the 3MMD, that when patients don't collect or patients do not adhere, then it becomes a problem with the 3 months. So we also moved to 4 months. Yeah. Thank you.
Thank you very much. Yeah. Thank you, Mulisame. Very informative. There's a lot there we can pick up. So given that we are running out of time, I thank you, both of you. And I hand now over to Jackie. Over to you, Jackie.
Thank you so much. I think the fact that we have run over time indicates just how much depth and additional conversation this still deserves. Hopefully, this is just the first of ongoing cross learnings and collaboration across our 3 countries. I think some key points that came out. We've heard that there's a need for collaboration. Political will is essential. And I think just by the delegates we have here today, especially from Malawi, it shows that there is political will. And there are some key items and key learnings we can take, especially in terms of managing the supply chain to support this type of effort. I just want to say thank you all for coming, for being engaged, especially to our presenters for preparing slides and talking with such authority and passion about their work. And we look forward to ongoing conversations. We will share the slides and the recording with colleagues after this session. And next week, when we are in Malawi and coming together, we will also just touch on some of the key takeaways today. So thank you all, and I hope you enjoy the rest of your day and your weekend.